There are a lot of different agents available today commercially to treat myelofibrosis-associated anemia. We think of two main categories. One are just straight anemia supportive agents, things like ESAs, erythropoiesis stimulating agents, luspatercept, and danazol. These are drugs that really just improve anemia in patients with myelofibrosis. We often use them in related diseases like myelodysplastic syndrome as well. And they really don't have any impact on the rest of the disease presentation or disease biology to the best of our knowledge. And again, we focus on using these drugs in patients who have just anemia and don't have overt splenomegaly or symptom burden. It can be used with or without JAK inhibitors, which I think is a very important thing to note. Just because a patient is not on a JAK inhibitor doesn't mean you don't have to address their anemia. And likewise, if a patient is on a JAK inhibitor and doing well, their spleen and symptoms are under good control, you can add on one of these agents safely with the JAK inhibitor to improve their anemia. The other major kind of category of therapy for myelofibrosis-associated anemia are the JAK inhibitors that also inhibit ACVR1. That is pacritinib and momelotinib. So by inhibiting ACVR1, they lower hepcidin levels, treating the anemia of inflammatory block. It's kind of a two for one, right? So with the JAK inhibition part of those drugs, you're treating the spleen and symptoms, but with the ACVR1 inhibition of those drugs, you're treating the anemia, the myelofibrosis-associated anemia. At least that's due to, in part, to elevated hepcidin levels and inflammation.